consultant at Aravind Eye Hospital, Coimbatore, to talk about pseudomelanomas.
Hello. Okay. First of all, thank you, AOS, and my colleagues and senior colleagues and friends. So today I'll be talking about pseudomelanomas, the tumors which mimic like melanomas, but actually they are not. So from anatomical perspective, most of the melanomas we see in the choroid, followed by ciliary body region, and then the iris. So when do you know it's a tumor malignancy? So if you see iris melanoma, it should be tumor size at least 3 mm in diameter and 1 mm thickness, and lesions with largest basal diameter greater than 3 mm. And there will be some distortion of the iris with ectropy on UVA. There can be intrinsic vascularity, and there can be sectoral cataract and secondary glaucomas. So these are the pseudo iris melanomas which we commonly see in day-to-day practice: primary iris cyst, iris nevus, iris foreign body, metastasis, melanocytoma, leiomyoma, and adenoma of the iris epithelium. So this was a clinical study of 200 patients by Shields group, and they found that iris cyst comprised of 38% of the tumors, followed by iris nevus, which were 31%, and then some other conditions like iris foreign body, peripheral anterior synechiae, and iris metastasis. This was a clinical survey of more than 3,000 iris tumors based on patient age at presentation by Shields group. And the spectrum of the iris tumors included cystic tumors, which were 21%, and solid tumors, which are almost 79%. And the solid tumors were either melanocytic, which were 68%, and non-melanocytic, which were 11%. And at all ages, the most common specific diagnoses were nevus, which were 42%, followed by cyst and melanoma. So this was one of our case, 21-year-old male who complained of colored halos, and he noticed a growth in the right eye, you can see inferiorly. And it was a dark brown pigmented mass with feathery margins involving 2 clock hours. So already patient went somewhere else and he was started on anti-glaucoma medications. We did a UBM, we found the iris thickening. There, the iris surfaces were both anteriorly and posteriorly, and it had infiltrated the iris root, ciliary body, and extended into the anterior chambral angle. And he also had a MRI report which he did outside, which showed a small T1 hyperintense and T2 hypointense lesion involving iris inferomedially to lens, which showed signs of melanoma. Ultrasound abdomen was okay, only a tiny simple cyst. So all the blood investigations were normal, and there was a dilemma whether it is iris melanoma or iris melanocytoma. And we told the patient to observe and follow up after 4 months. Now, after 4 months, patient came with conjunctival congestion with prominent episcleral vessels. IOP was 40 in the same eye. Gonioscopy, gonioscopy revealed 360-degree angle pigments. You can see the pigments infiltration in the trabecular meshwork, which was 360-degree. So the glaucoma clinic added more additional anti-glaucoma medications, brimonidine eye drop and letinoprost, and we repeated the MRI before mass excision. Even the repeat MRI showed a small T1 hyperintense and T2 hypointense lesion involving the iris inferomedial to lens, which showed again signs of iris melanoma, but there was no extraocular extension. And then we excised the entire tumor, and it showed proliferation of nevoid cells with mature, densely pigmented spindle melanocytes and no mitosis. There was the involvement of ciliary body and extension to iris, and it was a sign of spindle cell nevus. So it was not a melanoma. And follow-up was fine. This is again another case. You can see a pigmented lesion. Usually these iris nevus, they are stromal lesions. So they can be diffuse epithelioid or balloon shape. This is again iris melanocytoma, which usually have these feathery margins. So this is 3% of the iris nevi. This is a pigment variant of the melanocytic nevus, and they have a predilection for the iris root. This is iris cyst. I'll just skip it. This is a ciliary body melanoma. You can see a dilated episcleral vessels with sentinel vessels, and then you can see a pigmented mass behind the iris. So these ciliary body melanomas can be circumscribed or annular. So this was a case, again, similar case we noted few years back, but this was published in a different paper. So it's a 20-year-old girl who noticed a small growth behind the iris, and they done excision with iridocyclectomy, and uh, they thought, again similar to our case, that we thought that it's a ciliary body melanoma, but HP showed follicular carcinoma of thyroid. So it was a metastasis of thyroid carcinoma to ciliary body. So from that, we have learned that history of thyroid surgery is very important. In the similarly, in our case, the patient had a history of subthyroid, subtotal thyroidectomy. Now coming to the melanomas of the choroid and ciliary body. So pseudomelanomas of the posterior uveal tract. So this was a 2006 Taylor Smith lecture by Shields group. Again, they showed that the frequent condition which mimic choroidal melanoma was a choroidal nevus, which comprised of almost 49% of the pseudomelanomas, followed by peripheral exudative hemorrhagic chorioretinopathy, PHCR 8%, and followed by other conditions like hemorrhagic detachment or choroidal hemangioma or ARMD cases. So this was again a 47-year-old female complained of dry cough and decreased vision in right eye since 1 month. You can see there are multiple multinodular swellings in the posterior pole, also inferiorly. In the other eye also, left eye also, patient had some mass-like lesions posterior in the posterior pole, and finally it revealed it was a case of choroidal metastasis, and patient had a primary lung carcinoma. Similarly, this case, you can see there is a exudative RD in the right eye, and B scan also showed a mass-like lesion, but again it was a choroidal metastasis with primary lung carcinoma. You can see a smooth round-shaped contour. And this was a 45-year-old male who complained of left eye defective vision since 1 month. And you can see there was a mass with few exudates in the periphery, and OCD showed subretinal fluid and with fibrinous exudation. So this was a nevus with SRF, and Shields group showed that 16% of the nevus can be with SRF also, and it nicely resolved with post 3 injections of Avastin. So I'll skip quickly. This is a 67-year-old incidental finding. It was a nevus only. And this is a RP adenoma with quite a mass, black pigmented, and few exudations. And this was an interesting case. 62 years old female complained of left eye watering with pain. MRI was done somewhere else, which showed signs of choroidal melanoma. And there was a large mass from 10 to 2 o'clock. These can also show 19 by 7.5 mm, and we did enucleation of the patient, the eye. But it showed proliferated polygonal epithelioid cells with abundant granular eosinophilic cytoplasm, and it was a perivascular epithelioid cell tumor of the ciliary body, PCOMA, very rare, and it had no mitosis, pleomorphism, or necrosis. This was a regular checkup. Patient lost to follow-up actually. Thought of the B scan of this patient showed no internal reflectivity, no choroidal excavation. It was a hypoequic lesion, possibly choroidal granuloma, but patient lost to follow-up. And this was a patient where the choroidal melanoma simulated like adenoma of the RP arising at the site of congenital hypertrophy of the RP. FNAB for this patient is very useful, so we can do FNAB for cytopathology and cytogenetics. So this was a patient came with decreased vision, with exudation and mass-like lesion just superior to the disc. And they did a FNAB of the choroidal mass, and it showed metastatic adenocarcinoma. And when they did systemic evaluation, it showed non-small cell lung cancer, and which had metastasis to the eye and the brain, and patient was started on systemic chemotherapy. Okay. So conclusion is uveal melanoma is very complex condition. It requires a multidisciplinary approach to management and treatment. Early detection and therapy are very important in the disease survival. And also it is very important to distinguish for the mimickers, because there are a lot of pseudomelanomas, and careful slit lamp examination and imaging plays an important role to rule out melanoma and other conditions. Thank you.
Thank you, Dr. Abhishek. So, next, is there any doubt? Want to clarify? So A scan features of choroidal melanoma and metastasis just it's just the opposite. Like you have the initial high spike and the lowest acoustic hollowing, which is typical of melanoma, will not be seen in metastasis. It will be inverted, so that we can just
You have to see the internal reflectivity. That's
fertility
very
side.
important. Yeah. Yeah.
Thank you. I'll be talking on masquerades in pediatric oncology. So, good morning. Pediatric ocular tumors are very rare, but vital to diagnose because they are going to be life threatening. So, most common intraocular malignant tumor is retinoblastoma. Then comes the medulla epitheliomas. The leukemic infiltration is quite rare, but they are do common neuroepithelial tumors. Malignant appearing benign lesions are the retinocytomas, the amatomas, and hemangiomas. So the true masquerades, actually, the it looks like a persistent presentation is like a persistent fetal vasculature, but it turns to be a medulla epithelioma or a leiomyoma. And retinoblastoma, we know all those pseudogliomas, that leukocoria presentation. The most common mimicker is going to be Coats disease and also infective etiologies. So if you see the case one, it was a 7-month-old female child who referred as endogenous endophthalmitis. On examination, the child had circumcorneal congestion. There was a pinkish yellow globular mass on the iris at the fourth claw cover, and there were also few nodules on the iris surface. Both the corneal diameter and axial length was symmetrical in both the eyes. There was a retrolental fibrovascular membrane. So this mimics PFV, but ultrasound was normal. There was no evidence of any and ultrasound biomicroscopy showed a large ciliary body mass in the infratemporal quadrant with fibrosis, with iridocorneal adhesion, and with opacified lens. So the differential diagnosis was whether medulla epithelioma or is a juvenile xanthogranuloma. Excision biopsy was done, and we were able to see a lot of Taunton chain cells, and stroma showed infiltration of eosinophils and histiocytes suggestive of a juvenile xanthogranuloma. So this another case was a 9-year-old female child with good visual acuity, presented with a shallow AC in the right eye, and temporal part of the lens was opaque, and there was a fibrovascular tissue and a non-pigmented vascularized mass. The fundus show temporal dragging of vessels, and as expected, the ultrasound biomicroscopy showed a hypoechoic lesion in the temporal quadrant, and MRI showed a ciliary body lesion. Excision biopsy was done, and we can see a mass with fibrovascular tissue with histopathological features suggestive of medullopithelioma. Oncologist referral was done, and the PET CT showed no other metabolically active tissue. There's another case, a 2-year-old boy who presented with white reflex in the right eye. He had a pigmented vascularized mass the 8th to 10th clock hour, and there was a fibrovascular tissue attached to the PC, which was a retrolental fibrovascular tissue mimicking a persistent fetal vasculature. Ultrasound biomicroscopy showed a cystic lesions at the ciliary body area, and MRI also showed a ciliary body lesion. And referred as we planned for the excision biopsy, and we found there was no obvious mass, but there was a cyst lesion with the fibrovascular tissue which was excised, and histopathology showed neural differentiation in them, and it turned out to be a leiomyoma. So, mimickers of advanced retinoblastoma, as Collins called it in 1892, any condition which resembles retinoblastoma is the pseudoglioma. So, all this NDP-related retinopathies which present with a white reflex is one of DD for retinoblastoma. And this is a 7-month-old male child who presented with white reflex in the right eye at 3 months of age. It's more like xanthochoria. You can see it's more of an endlo reflex, and we can see some subretinal exudations. And ultrasound biomicroscopy show close funnel RD with subretinal echoes, but you can see a dense echo collected like looking like a mass. But this dynamic B scan will help us to see whether the mass under whether the echoes underlying are mobile or not. If it is mobile, then there is no mass underlying. So this dynamic B scan is very helpful in case of when you have such confusions. And the more typical of Coats disease is the telangiectatic vessels with light bulb aneurysms, which can be very clear in this picture. This child underwent a subretinal fluid drainage, and the fluid was sent for analysis, and there were no malignant cells. So, if it's a unilateral child, if it's a male child with the first decade of presentation, you see telangiectatic vessels with aneurysms, and the dynamic B scan shows there is more mass, then you're dealing with the Coates disease and not retinoblastoma. So, other mimickers, as I told you, cataract is obvious, the B scan will be normal. ROP and FEVR are more a temporal oriented disease, means you have a retroventricular fibrovascular tissue, but it is mostly attached with the retinal fold, temporally oriented towards the lens. And persistent fetal vasculature is more the nasally oriented disease. And B scan will definitely help us, will say as there is no mass lesion. And dynamic B scan, as I told you, will be helpful to rule out Coates disease. There are pseudogliomas because of this ROP telescreening. We are picking up earlier new retinoblastomas and other confusions. Like when we see a mass, we always very scary because we don't know how it is going to progress. So this was a child with screen for ROP, and we found a mass lesion at the posterior pole and another lesion the mid periphery. It increases in size in day 7. So there was no calcification and there is no much vascularity. It's more looking infective lesion. And we asked pediatrician to rule out the systemic workup, do a rule of sepsis, and we asked them to start a systemic antibiotics also. And we referred to the base hospital. We did a biopsy, and actually there was no growth for identified, but we gave a broad spectrum antibiotic, and the lesion healed with scarring. So another patient and a screen in ROP, and for ROP telescreening was done, and we don't see any lesion. There was subtle lesion in visit 1. In visit 2, you see at the macula a slightly elevated lesion, and we suspected some mass lesion, and we referred to the base hospital. There was no vitritis. There was actually there was no evidence of any sepsis also, which was ruled out by the pediatrician. There was no calcification, and partly when we refer to the base hospital, we see partly scarring lesion. So we asked for torch titer also because we have to think of chorioretinitis, other torch infections, and it turned out to be CMV retinitis positivity. And with the 4th visit, we can see almost like a scarred lesion. So when you see a small lesion sitting, and just with follow-up, with systemic workup also, because all patients in the neonatal period are immunocompromised. You don't expect any vitritis, which will clearly say if there is infection or not. And when there is no obvious calcification, when there is increase in size with your follow-up, but it scars, it's morely an infective lesion. Why I'm saying this is another patient with presentation of plain full blind eye in the left eye, and it mimics like a group E retinoblastoma, and another lesion at the posterior pole with the group A retinoblastoma. It was diagnosed as retinoblastoma. We enucleated the left eye as it was as a group E mass, which was also painful. And histopathology shows astrocytosis with chorioretinitis. There was no evidence of retinoblastoma. Retrospectively analyzed, there was epilepsy and ash leaf macules, and MRI also showed ependymomas in the brain, and the diagnosis turned to be a tuberous sclerosis. So this is another case with the previous case in our mind. The 3-month-old kid was referred by the pediatrician with history of seizures, and we saw these mass lesions sitting in the posterior pole. And since we are aware that we had some experience in the past, we thought it could be a tuberous sclerosis also, and we asked for the pediatrician to look for it, and there were hematomas in the brain, and diagnosis turned to be a tuberous sclerosis. So this is another interesting case. You see a lesion at the preterm child screened during ROP and found to have a mass lesion in the posterior pole. There is no vitritis, but there was a Venflon site infection. There was systemic sepsis for this child. So we thought more of an infective etiology only. But ultimately on day 15, we found there was some calcific specks in that developing in that child. So we did a genetic testing and found out the child to be having a mutation in the RB1 gene. And as there was no resolution with transpupillary thermotherapy alone, we started intravenous chemotherapy. So this is another case of it's just a 5-year-old boy bought by the parents with a complaint of squint. The younger brother was already diagnosed with bilateral retinoblastoma. So it's obvious, like you can see a mass lesion with cyst, with RP degeneration. All these go in favor of a retinocytoma. And there is no change in the size of the child, almost following him for more than 2 years, and there is no change in the size. So that is retinocytoma. This is the fundus of the younger sibling. You can see there is group A lesion, B lesion, and group E in the left eye, which were good regression with chemotherapy. This is another such family. We're showing retinocytomas and scarring in the left eye. So these are the newer pseudogliomas which I want to highlight on, that amartomas, infective lesions like endogenous endof or CMV retinitis or toxoplasmosis can mimic early retinoblastomas. And even retinocytoma is a close mimicker of retinoblastoma, which is well known. So thank you. So I request Dr. Parak sir to talk about uveal distractions, about lymphomas and masquerades.
Yeah, the outside like to thank Dr. Prema for this opportunity. Yeah, so I'm very happy that we have one person in the audience and that no other than Mahesh Shanmugam sir. So thank you, sir.
I started when I saw this, sir.
So uveitic distractions, lymphoma and metastasis. So these are the things which can mimic a posterior uveitis. And the salient points of both are usually they are in the elderly age group, predominantly posterior segment involvement. And even if it is involved the anterior segment, it is usually a painless white uveitis, bilateral but not always. And uveitic workup is obviously negative. So intraocular lymphoma, it's a non-Hodgkin type B-cell lymphoma, and there's a primary and secondary. And primary is usually maybe associated with a CNS involvement. It's called as a primary vitreoretinal lymphoma, which is a high grade and more lethal. Then the secondary type, which is a metastasis from outside, is a low grade choroidal lymphoma, usually from the GI tract. So it's mandatory wherever you suspect a lymphoma, always do a neuroimaging and find out if there is any, because that all changes the entire management. And from ocular, it goes to the systemic treatment by an oncologist. The clinical features, as we know, are the multifocal subretinal epithelial infiltrates, which are pathognomic, and they can be associated with vitritis. And these pigments in 70% of the patients, and 20% can have anterior uveitis also, but it is usually a white uveitis. Again, when you see clinical features, history taking, always ask for CNS symptoms, and you will find that if there is a behavioral changes or something, then you must suspect that there could be CNS involvement, and always do a neuroimaging. And there's a PET CT showing that the lymphoma infiltrates in the brain. Other rarer type of presentations are choroidal mass, exudative retinal detachment, or optic disc swelling, and vasculitis with retinal hemorrhages can also present a lymphoma. Ocular investigations, we know the OCT now is one of the key imaging for diagnosis, and we can see the hyperreflective nodules at the level of the RP or sub RP. Along with the clinically, you can see these infiltrates. And fundus autofluorescence will show hyperautofluorescence surrounded by hypo, and the opposite by the fundus fluorescent angiography. So when it comes to diagnosis, always do a systemic evaluation first, rule out any systemic manifestations with doing an MRI, USG abdomen, and if required, a PET scan. If all is negative, then you go ahead with your vitreous biopsy. And biopsy, you do in two things, undiluted and a diluted sample. Undiluted sample is usually around 1 to 2 ml. It's difficult to get it, but it can be done under air now. And diluted specimen from the vitrectomy cassette can be performed for the additional test. And it's mandatory that if the steroids have already started, then we should stop it before doing the biopsy, because it might come negative. And very important, the tissue has to be transported immediately. It's best to have a pathologist within in-house. If not, then within 60 minutes it has to reach to the lab. And if you expect some delay, then you have to fix it with ethanol, methanol, propanol, but that's not the ideal situation. And the test with the pathologist perform the cytological evaluation examination, which is the most diagnostic thing, but however, the sensitivity is a little low in that. And the immunohistochemistry of CD22 and measurement of cytokine levels, and of course the molecular examinations with the MYD88 genetic mutations are the recent ones. And if the vitreous biopsy comes negative, then only you can go ahead and go with the more damaging retinal and the retinochoroidal biopsy. Ocular treatment, that whole globe EBRT is still it's fine. You can give a 40 gray in 15 fractions, but the side effects are cataract, radiation, retinopathy, dry eye. And now the intravitreal methotrexate, intravitreal chemotherapy with methotrexate and rituximab. The methotrexate was used initially and still being used. However, the regimen which was followed, which is quite intensive with weekly 4 injections and consolidation, weekly twice, then weekly once, and then monthly, almost 25 injections. and it ends up with a lot of keratopathy and other side effects. And so now there's a modified regimen which has only 7 injections. Like you give once a week for 1 month, 2 weekly for a month, and one for a month, and then wait and watch. And this is a recent case we saw in a clinic, and we are finding this modified regimen, and she's finished 6 injections of this regimen, and it's doing pretty well. The patient, they got some keratopathy, but otherwise it's doing fine. Rituximab is a little costlier and a little less intensive because you have just to give 1 injection a month. But the thing is that it can also have uveitis, and you be careful that you treat that, or you pick it up early and treat that also simultaneously. So this was a 20-year-old female with a subretinal yellowish mass and exudative and we sent for a evaluation. The oncologist did a PET scan. They found a lot of nodes involved everywhere. They did a biopsy, and treatment was started and regressed well, but it turned out to be tuberculosis and not a lymphoma. We can see that the age is quite less, not for lymphoma. This is a 23-year-old female. We saw a defective vision of 2 months, and you can see this hypopigmented large mass lesion on the posterior pole, and the B scan shows a calcification. So this is a case of a choroidal osteoma, mimicking like a lymphoma. Now coming to metastasis, bilateral multifocal, not always, but usually located preferentially at the posterior pole, and macula is involved in 42% of the eyes. So there are 3 forms: the flat amelanotic tumor with indistinct margins, as you can see here, the pigmented tumors with distinct margins, as seen here, and a large amelanotic dome-shaped tumor, as seen in this figure. Now, this case was already shown by Dr. Abhishek about the 47-year-old female who just came with a defective vision of 1 month duration, and you can see these nodules. But the point I want to highlight is that don't miss these subtle nodules everywhere else. You can see this, and this was taught by Dr. David Abramson even before the OCT era. That, and he correlated this to the peanut butter, the crunchy style. So we all like the peanut butter with the crunchy style, but the crunches are all hidden somewhere. So always look for that. In metastasis, you may see an obvious one mass, but then there'll be the entire choroid might be studded. And now we know with the shields, when they come with a lumpy, bumpy choroid, it's nothing but the same thing what was given by David Abramson even before the OCT era. This again was shown by my colleague. This is actually a large mass lesion, melanotic, mimicking like a melanoma, but actually the patient had a CA lungs, and we did a EBRT, and post EBRT you can see that it just melted out the tumor. Again, this patient came with a defective vision 1 month duration, this flat amelanotic lesion with like a CSR like thing referred to us, did a fluorescent angiography, and you can see the early hypofluorescence with the late staining and this multifocal RP pinpoint leaks, and we referred to the oncologist, and it turned out to be a stage 4 CA lung. This patient came with a bilateral disc edema, diploma. There was a mastectomy and chemotherapy radiation were done for breast cancer in 2018. And we did a B scan, and B scan, you can see this donut sign. And then it turned out to be a papilledema, actually, severe form. And it showed the metastasis of the leptomeninges. So this was the metastasis of the brain coming in the eye as a papilledema. So in conclusion, intraocular lymphomas and metastases are great mimickers of posterior uveitis. Careful history taking, clinical examination, multimodal imaging, and systemic evaluation can help in early diagnosis and proper management. Thank you.
Thank you, sir. It was an excellent presentation. Any questions for sir? I request Dr. Vijay Madam to talk about the Masquerades in Orbit and Oculoplasty. She is the head of the Department of Orbit and Oculoplasty at Aravind Eye Hospital, Coimbatore.
Good morning Today I'll be speaking on masquerades in orbit and oculoplasty, that is, masquerades of eyelid and orbital tumors. So, after all, what is a lie? It's a truth in a masquerade. So, masquerade in ocular pathologies often represent a diagnostic dilemma for clinicians because of their varying and atypical presentation. So, any suspicious lesion in the eyelid or orbit has to be evaluated meticulously. You have to do a protocol based approach with a temper based taking history with a precise organized approach for the clinical findings and evaluation and appropriate investigation and a rational intervention for coming to a conclusion and treatment. So some of the red flag signs I'll be discussing along with the differentials. So case 1 was a 68-year-old male who presented with swelling and pain in the and redness in the left eye of 4 months duration. He had a superior bulbar conjunctival mass with feeder vessels with mild proptosis and restriction of abduction. You can see he has got a mild proptosis in the left eye. There were no regional lymph nodes. We clinically diagnosed as conjunctival lymphoma. So MRI also revealed conjunctival lymphoma with suspicious involvement of the lacrimal gland with LDH raised, but incisional biopsy proved to be a moderately differentiated squamous cell carcinoma. So oncologist opinion was taken to rule out systemic metastasis. He was started on mitomycin C, but no response. And UBM was again done by the radiologist for posterior segment of scleral invasion. And UBM was done by the retina consultant, and B scan was again done by the radiologist. And there was no lacrimal gland invasion. So he was managed by excision of the conjunctival mass with AMG and cryo. So coming to the differences between the squamous cell and conjunctival lymphoma, laterality squamous cell carcinoma is unilateral. Lymphoma can be bilateral or unilateral. And clinically, the squamous cell carcinoma has an elevated gel-like mass with feeder vessels with or without surface keratinization. And lymphoma appears like a salmon-colored lesion and usually arises from the B cells. An origin of squamous cell carcinoma, the histopathology, they arise from the squamous cell layer, and keratin pearls or intercellular bridges are very characteristic of a well-differentiated carcinoma, whereas origin of B cell is a origin of lymphoma is from the B cells, and low-grade lymphomas are extranodal marginal zone lymphoma or follicular zone lymphoma, and diffuse large cell and mantle are high-grade lymphomas. Case 2 was a 68-year-old female who presented with right eye watering and a swelling in the right eye for the past 3 months. She had an inferior pharyngeal mass with scleral thinning, no lymph nodes, and she was clinically diagnosed as OSSN or squamous papilloma. MRI also showed a effacement of the conjunctival plane, which involved the inferior oblique muscle, but incisional biopsy revealed a moderately differentiated squamous cell carcinoma, and this case was managed by lid sparing accentration. So a squamous cell papilloma is caused by a human papilloma virus, and it appears as a sessile or pedunculated mass with a fibrovascular core and hyperplastic epithelium, whereas squamous cell carcinoma is most commonly caused by UV radiation, HIV and AIDS patient, and also can be a HPV virus. And these patients, as I said, they have a gelatinous or papillomatous appearance with inflammation and leukoplakia. Case 3 is a 58-year-old female who presented with complete ptosis and protrusion of the left eye, and she had defective vision in the left eye for the past 11 months, no trauma or no fever, and she had a proptosis with inferior dystopia with complete restriction of all extraocular movements, and there was a firm ill-defined non-tender mass in the supratemporal orbit which was fixed to the bone and the skin extending to the infratemporal orbit and with mild dilatation of the vessels, and there were no regional lymph nodes. Clinically it was looking like a lymphoma, but MRI also said lymphoma or histiocytic or non-infective granulomatous disorder, but incisional biopsy came out as a ductal carcinoma of the lacrimal gland. These lacrimal gland carcinomas have very high morbidity and mortality. So, and also we have to first do a systemic workup to rule out a distant metastasis. And this patient, since she had a very large tumor, underwent accentration. So the lymphoma can be well defined, molding to the globe, whereas lacrimal gland carcinoma can be well defined or infiltrative. Calcification is very characteristic, can be present 30%, and bony erosion are present. And then IHC also helps in differentiating the lymphoma from the lacrimal gland carcinoma. Case 4 was a 75-year-old man who came with acute onset of redness and discharge in the left eye, and there was a history of trauma. He underwent keratoplasty in the right eye. Vision in the left eye was 5 by 60, and right eye showed thickened upper lid and lower lid margin with foreshortening of the fornices. So clinically, both eye he was diagnosed as OCP with left eye sterile corneal melt, and he was started on oral and topical antibiotics, and biopsy was already done elsewhere, which showed as conjunctival intraepithelial neoplasia. But second opinion, we got the second opinion slide box, which showed disc keratosis with moderate sin type 2, and he was started on local mitomycin C. 2 cycles were given. So the difference is sin has a gelatinous appearance with and more commonly in the interpalpable region with feeder vessels, and it contains a mixture of spindle and epidermoid cells. And one important thing is it has a clear demarcation between the normal and abnormal epithelium, whereas OCP has a linear staining of the epithelial basement membrane and has foreshortening of the conjunctiva and fornices. And this is a 57-year-old male who came with who came with a recurrent redness and pain, and she considered local ophthalmologist, was treated as blepharitis or keratoconjunctivitis, and she had a thickened lid margins, diffuse congestion, and ESR and all the granulomatous workup was negative, and she was diagnosed as chronic conjunctivitis as with limbal cell deficiency, and she was not responding to any of the lubricants. So biopsy was done, and she came out as Pagetite variant of sebaceous gland carcinoma, underwent a systemic workup, and finally we did a lid sparing excitation with an orbitoocular prosthesis. So why this case is sebaceous gland carcinoma has a non-specific clinical presentation. Pagetite the tumor cells can migrate to the epithelial surface and cause skip lesions mimicking a benign lesion like blepharoconjunctivitis, and it's very difficult to diagnose because the average time interval between the presentation and diagnosis ranges from 1 to 3 years. So delayed diagnosis can lead to significant morbidity. The poor prognosis causes an invasion of the vascular lymphatic system, bilateral involvement, pagetoid invasion, tumor diameter more than 10, and delayed diagnosis. So coming to the next case is a 57-year-old male. He presented a small lesion in the upper lid, which was not, it looked like a chalazion, but on eversion, there was a white yellowish proliferative lesion, and this came out as a high-grade sebaceous carcinoma, and he underwent a wide excision with Cutler beard procedure. And okay, so this is the difference between the chalazion and the sebaceous gland carcinoma. The yellowish nodules with effacement of the lid margin and meibomian glands is very characteristic of a meibomian gland carcinoma. This is a patient who came with bilateral ptosis with nodules in the conjunctiva, and she had mild edema and lid edema with conjunctival masses, and she was diagnosed as conjunctival lymphoma, but biopsy showed as amyloidosis. And similarly, another case who came with unilateral ptosis, she also had an amyloidosis, and this can only be diagnosed by doing a HPE, where you can see that by staining with Congo red stain, you can have an apple green birefringence which is seen in the cells. And this is a patient who presented with left eye swelling and with a caruncular mass. It came out elsewhere. It came out as a benign squamous papilloma, but repeat biopsy showed an invasive carcinoma which was invading the nasal cavity and medial orbit, and he was advised total excision but loss of follow-up. And this is a case a small child, a 9-year-old, who presented with a right eye conjunctival mass of 1 month, no history of weight loss or no fever, but and we thought it was a lymphoma or a granuloma, but peripheral smear showed increased neutrophils with thrombocytopenia, and she had lymph nodes in the cervical region, and biopsy came out as myeloid sarcoma, and she was referred to oncologist for further management. And this is a large tumor in the left lower lid, and we thought it was a squamous cell carcinoma, but biopsy showed as desmoplastic tricholemmal carcinoma, which is a hair follicle tumor, and this is after the lid reconstruction. And similarly, this was also a tricholemmal carcinoma, and these tumors, they mimic a basal cell carcinoma. So this was after excision, and the difference is in basal cell carcinoma you have a retraction artifact. That means the basal cells, they show a peripheral palisading, whereas even the hair follicles tumors, they show the same thing, but there is a retraction artifact, or there's a space between the stroma and the tumor cells. Just one more slide. And this is a case, 38-year-old lady who came with a right eye lower orbital mass. ESR was raised, and we thought it is an inflammation or a vaginose, but biopsy showed as eosinophilic angiocentric fibrosis, and the treatment for this is a surgical debulking and oral prednisolone. And this was a last case, which she's a 23-year-old child who came with sudden protrusion of the left eye for 3 weeks, and she was already diagnosed as CMV optic neuritis in our hospital. And but the loss of vision was sudden for 3 weeks, and MRI revealed lymphoma or granulomatous etiology. She was already a case of IG he was a case of post-renal transplant. So biopsy came out as lymphoproliferative disorder. So we have to always keep in mind that it's not just an ordinary inflammation. These immunocompromised patients can also have a post-renal transplant lymphoproliferative disorder. So last case is a 40-year-old female with left eye upper lid swelling. She underwent complete excision of the mass. We thought it's a sebaceous cyst, but finally it turned out to be dirofilarosis. So this is not a masquerade, and this is just a child, and we were diagnosed as conjunctival melanocytic nevus, and biopsy came out as a compound melanocytic nevus. So these cases have to be actually followed up very frequently, because they can always become malignant, these masses. So it's not a masquerade, but we just presented to show the importance of this follow-up. Thank you.
Excellent presentation. I showed a lot of cases and very impressive. I think any questions for ma'am? Okay. I'll call the next speaker, Dr. Mangla. She's HOD of Cornea Department at Aravind Hospital, Coimbatore, and she will talk about OSS and mimickers. Sure.
Good morning, everyone. Good morning. Now we have seen lot of posterior segment and then lid and orbit. Now we are going to see the mimickers of ocular surface squamous neoplasia. So as we all know, it is an important pathological entity. It closely mimics so many conjunctival and corneal pathologies. So here we are going to see a few very common pathologies I'm just going to show you. So these can be differentiated from the other tumors by using various modalities like OCT, impression cytology, confocal microscopy, and ultrasound. So these are the mimickers of OSSN, and so this is the first patient who is a 45-year-old male who had a pterygium excision, and then the patient came with this kind of lesion after a few months. So then this was looking like a OSSN, but it is not. It is just a pyogenic granuloma. Actually, it's a misnomer. It's an exuberant granulation tissue. It's a response to insults as surgical or non-surgical trauma. It's usually a rapid onset, fleshy, elevated, rich vascular mass. It can be round or ovoid. And if you excise, it is a very simple thing. And if you excise and send for HPE, there will be a lot of granulation tissue with lymphocytes, not a OSSN. So usually responds to topical steroids in early stages, but if it is large and persisting, then we have to go for the excision at the base, followed by cauterization or cryotherapy of the base of the lesion. So we have to also take care of the inciting factor, and so that we can minimize the risk of recurrence. Very exuberant recurrence can be treated with low-dose brachytherapy. So this is another patient. You can see this is a lesion in the limbus, having a limbus mass with a few dilated vessels, congestion. Patient came with complaints of pain, redness, irritation. It's like looking like a OSSN, but it's a then when we went for the surgery, it is a normal pterygium, which is the next photograph you can see. This is always diagnosed clinically, but rarely we can have pterygiums such, like my first picture can present like that. So it's a very simple diagnosis of clinical appearance. And so when there is a leukoplakia, pigmentation, or irregular feeder vessels, then we have to have the suspicion of malignancy. So the surgical interference is only excision of the lesion, and we have to send for HPE. So in ASOCT, we can see the pterygium, the epithelium is of normal thickness with subepithelial fibrosis, but in OSSN, the epithelium will be appearing thickened and hyperreflective. So another close mimicker is a pincicula, is a raised yellowish white mass lesion we have all seen. Sometimes this can also mimic a OSSN. So this is another another different patients who came with similar complaints of pain, irritation, very minimal pain, but more of irritation and mass persisting for a few months. And this also is a raised mass, not in the exactly in the limbus, but one is close to the limbus, another one is a conjunctival mass. And there are dilated vessels, but not actually any feeder vessels, closely mimicking OSSN, but they are not. This is a conjunctival cyst. It's a thin-walled benign cystic lesions with non-keratinizing epithelium. Mostly they contain serous fluids. And etiology is congenital, or sometimes secondary cyst can happen spontaneously, or to various inflammatory condition. Any inflammation can cause, like such as pterygium, pinguculitis, keratoconjunctivitis, anything can cause conjunctival cyst, and even post-surgery you can have a conjunctival cyst. This is another one patient who had a large conjunctival cyst presented to us very lately after a trauma. So mostly it's a clinical diagnosis, but has to be confirmed with HPE. ASOCT and UBM will help us to find the extension, size, and shape of the cysts. Mostly it will disappear spontaneously, but persistent cases we have to go for surgical excision. And sometimes a YAG laser of the cyst can also be performed. So this is another one mimicker. Here we have two different lesions, one in the limbus, another one is in the near the lacrimal area. And I think we are all very sure about the diagnosis, but sometimes rarely a small one, slow and early lesions can mimic a OSSN. So this is a dermoid. It's a well-circumcised yellowish white solid lesion involving the corneoscleral limbus. Usually it's a cosmetic blemish, but sometimes it can cause severe astigmatism and amblyopia. Histopathologically, it's a simple choriostoma malformation with dense fibrous tissues and with deeper dermal elements like hair follicles and sebaceous glands. This is another one, the same dermoid, but location is different. It is in the conjunctiva. It's a conjunctival dermoid, and it is a mimicker of a OSSN. So treatment is observation alone, and larger dermoids needs excision. And if the defect is small, we can go for amniotic membrane. If it is larger, we have to go for a corneoscleral graft. Usually cosmetic appearances will improve, but the astigmatic error will be there significantly even after the surgery. So this is a very common one which we will encounter in our day-to-day practice, but this is a larger one with a lot of intraepithelial cysts. It's a conjunctival melanotic nevus. We can have some small lesions also we can see, but this is a larger one, and it has a feeder vessel also. So usually a nevus is apparent in the first or second decade, and the epithelial cell starts migrating. And in the further migration occurs and cell resides in the stroma in the third and fourth decades. Usually we need not do anything for these patients, but when it becomes larger and when it has a feeder vessel, when there is a lot of pigment migration, leukoplakic transformation, then we have to go for excision. And otherwise observation is enough. This is another patient who came to us, is a 55-year-old male who came to us with a lot of pain, irritation and redness, and the lesion was there for more than 2 weeks, and the local ophthalmologist have treated them with a lot of lubricants and steroids, but the still patient came to us with these lesions. And this is also looking like a close mimicker of an OSSN with dilated vessels and lesion limbal location and everything. But when you see there is an ulceration over the lesion, and when we stained it was fluorescent positive, and then when we went ahead with the histories and all those things, and then we found out that it's a flicton. So it's a elementary form of inflammation of the conjunctiva, and it is delayed type immune reaction. So we have to, flictinosis is dependent on the location as well. They have mild to moderate irritation. Most commonly it is there in the interpalpebral fissure. It's a gelatinous nodular lesion with injection of surrounding conjunctival vessels. So they show some degree of ulceration, but early stages ulceration may not be there. So multiple nodules can be there in the surface. So that the same picture of the same patient, the Flickton was healing after he was the systemic condition was found out and the treatment was started. Usually, all the systemic evaluation has to be done, and required systemic treatment has to be taken care of. This is another picture. The patient is a small, not like a 15-year-old male patient who came with the picture like this, and we can see it's a 360-degree limbitis, and when we closely observe, we can see white spots, which is nothing but a Horner-Trantow spots, which is a desquamated epithelial cells. It's nothing but a VKC, a simple condition which can mimic an OSSN when it is presenting like this with pigmentation and everything. So we all know the typical symptoms. It's also a clinical diagnosis with symptoms like itching, photophobia, ropey discharge, blepharospasm, and it is also seasonally recurrent. When we go through the history, we can easily make out the VKC, but sometimes the clinical picture can mimic an OSS, and we have to have that is also in mind. The signs will be conjunctival, limbal, and corneal, like injection and Horner-Trantow spots, epithelial erosions, shield ulcers, etc. And the treatment, this is also the VKC picture, which presents very differently and can mimic an OSSN. The treatment we all know, it's steroids and mast cell stabilizers. This is another patient who came with no symptoms, only just a redness and just redness for a few months. And this is capillary hemangioma, and it's actually this is a small child, and the parents told it is there since childhood birth, but it was slightly increased in size. So it's a capillary hemangioma. Usually it is present at may not be present at birth, but appears in the first 6 months of life, and sometimes it changes in shape, but many of the times it will remain the same. So this is another one, AV malformation. This is also a patient who came with no symptoms, but these can closely mimic an OSSN. But just a AV malformation, we just kept the patient for observation. So,
Ma'am, if you can skip some slides.
yeah, that's all. This is my few slides, only just pictures. This is PANAS, which is closely mimicking OSSN. Only it's a PANAS, not a OSSN. CDK and this Salzmann nodular, these are all clinical diagnoses, but they can always mimic a OSSN. Thank you.
Thank you, ma'am. We just have 5 minutes, and I want Pooja to rush with her topic, like CAR, MAR, and
Yes, so without delay, I'll go into the topic. So the topic allotted for me is paraneoplastic retinopathy. Can I have my slides up, please? Yeah, so paraneoplastic retinopathy is a subgroup of an umbrella term called autoimmune retinopathy, which is a rare autoimmune degenerative retinal disorder caused by cross-reactivity of serum antibodies against the retinal antigens. Now, paraneoplastic retinopathy, as the name suggests, is associated with cancers, and there are 4 distinct entities now: the carcinoma-associated retinopathy, melanoma-associated, paraneoplastic vitelliform maculopathy, and bilateral diffuse uveal melanocytic proliferation, or BDAM. So if a patient comes with symptoms of shimmering or flickering of lights, with scotoma and transient decrease in vision, with a apparently normal looking fundus, what do? We usually tend to send the patient, reassure the patient, and send the patient back home. But if we have something non-specific fundus findings, we tend to look deeper. But what are we exactly looking at? So very important to know that these very vague symptoms can be associated with carcinoma-associated retinopathy. So because it's an autoimmune disorder against the photoreceptors, it can have non-specific symptoms associated with either rod dysfunction or cone dysfunction, so photosensitivity, glare, nyctalopia, etc. Important thing to note is the fundus can be absolutely normal or can have features like arteriolar attenuation, mottled RP, and disc pallor, which looks like retinitis pigmentosa, or can have something looking like uveitis, like mild vitreous cells, sheathing, periphlebitis, etc. So ERG is going to be again like retinitis pigmentosa, diminished photopic and scotopic responses with field changes. Now, like I said, it's autoantibodies against the tumor antigen that cross-react with the retinal proteins and result in the dysfunction. So multiple autoantibodies have been implicated. The most common is recovering an alpha enolase, and only in 65% patients we actually have a detectable autoantibody. Okay, so to bring it to everybody's notice that these autoantibody testing are done in very few centers across the world and are very expensive, and it's very difficult also to send the sample from here to another country because it has a lot of paperwork involved in it. So the take home point for carcinoma associated retinopathy is if a patient comes with recent onset of photosensitivity, ring scotoma, and has arteriolar attenuation or any of these features, look in for an underlying pathology, because visual symptoms precede the diagnosis of malignancy in up to 50% patients, and the associated malignancies can be small cell carcinoma or any of the gynecological. Okay, so coming to the next part, that is, so a 66-year-old gentleman came with recent onset of night vision difficulty, both eye cataract surgery done. Best corrected visual acuity in both eyes was 6.9 with few drusen. I don't have the fundus picture, unfortunately. So I did not know why this patient was suddenly complaining of night vision difficulty. But then her son came in and gave the history that her father was diagnosed with skin cancer 4 years back. And there I had a diagnosis of probably looking at melanoma-associated retinopathy. Here again, the fundus can be completely normal or can have, again, very vague, non-specific findings like white atrophic patches, diffuse RP atrophy, blunted foveal reflex, and visual fields are also going to show some changes. Now, in most of these cases, there is already an underlying diagnosis of a cutaneous malignancy, and that makes the job easier for us. If it's not diagnosed, we need to suspect and send for the appropriate workup. So pathogenesis here is the presence of an anti-rod bipolar cell antibody that is against the TRPM1 receptor. There are other associated antibodies as well, like transducin, aldolase, C, aldolase A, mitophilin, etc. What is interesting about this TRPM1 is that this TRPM is actually the mutation of TRPM1 receptor causes congenital stationary night blindness. So what do we expect in ERG? On bipolar cell dysfunction is going to cause an electronegative ERG, but in these cases, the night vision difficulty and the electronegativity of the ERG will be subacute in onset in an adult. Okay. So the third entity I'm going to talk about is the paraneoplastic vitelliform maculopathy. So they are these vitelliform lesions over the posterior pole at the level of RP associated with serous macular detachment. They closely resemble polymorphous vitelliform maculopathy and Best dystrophy, and are associated with both choroidal and cutaneous melanomas. Now, earlier these were classified under the melanoma-associated retinopathy, but increasingly there are reports of cases to be associated with carcinomas as well, and that's why now we have this in a different entity altogether. So the rarest of the entity is BDUM. So as the name says, it's bilateral. It has a diffuse melanocytic proliferation, and it often precedes the diagnosis of malignancy. And we don't know how it actually happens, but there is the role of a cultured melanocyte elongation and proliferation factor in this. So this is a late presentation, 6 to 9 decade of life with rapid onset of painless bilateral decrease in vision. Now, Dr. Donald Gass has given these cardinal signs. So they are these multiple subtle round red patches. And on autofluorescence, they will be hypoautofluorescence, but on FFA, they will be hyperautofluorescence because of the RPE loss. And there'll be diffuse thickening of choroid and with focally elevated pigmented tumors. They can be associated with exudative RD and rapidly progresses to cataract formation. Now, very easy to miss them when the pigmented tumors have not developed, because we think we are looking at a uveitic entity. And after the the pigments have appeared, we still can have many DDs. But what is important to remember that they are bilateral and they involve the entire uveal tract. So the survival of these patients is actually quite less, and plasma exchange has been suggested as a treatment. So now this is the most important slide of the presentation. If you have an adult with rapidly progressive bilateral unexplained vision loss, normal looking fundus or unexplained findings, and if your ERG also shows rod and cone dysfunction, plus minus if you can get an autoantibodies done. So you're looking at paraneoplastic retinopathy, and it warrants the systemic survey for malignancy. Thank you.
Thank you, Pooja. It was a very wonderful presentation. And we just out of time. Like, any doubts? So thank you for giving us extra 3 minutes. Thank you.